uveitis. Before I go further, I would like to introduce today's guest speaker. Of course, he needs no introduction to the audience, but I just wanted to highlight few of his achievements, rather his contribution to Indian and world ophthalmology. So who are aware of his tenure during in PGI would know that he was instrumental in transforming one room eye clinic to a advanced eye care center at PGI, which is one of the state-of-art eye care facility. And I have not seen a better eye care center in my short career as an ophthalmologist. And undoubtedly, it is one of the best centers in India. Further, he was the first president of USI, and he took an onus on himself to teach the art and science of uveitis to many. And this is being reflected by numerous illustrious teachers that we have now in uveitis, including JB sir, Anita ma'am, Vishali ma'am, and Reema Bansal ma'am, and the list goes on and on. And he has been inspiring many of us to take up uveitis as a specialty, which we usually would have not taken up before we have met him. His other contribution to ophthalmology is the number of publications that he has made. And I still remember last time when sir had visited Chitrakoot, he told us that if a tree fells in a jungle, does it make a sound? So that was the question that he had put. And so his emphasis has always been on the quality of publications rather than quantity. And you can see from the citations that he has got over the years. So you can have a lot of publications, but if it's not cited or seen or read, then it carries no value. And these are the pictures which I've taken from one of his publications in Survey in 2007. And it has got more than a whopping 650 citations. That's from one publication itself. So to conclude, if Sachin Tendulkar, we all know him as the cricketing god in India. If there has to be a god of ophthalmology, it has to be none other than Professor Amod Gupta. Sir, thank you so much for kindly accepting our invitation, and we'll not take any more time, and we'll start with the first presentation. Can we have the first presentation?
Yes, sir.
Gaurav.
Good evening, one and all. So today I would like to present a case of relentless progression of serpiginous-like choroiditis in a young patient. A 17-year-old female patient came to us with chief complaints of left eye diminution of vision for the past 3 months. On presentation, her right eye revealed a visual acuity of perception of light. In anterior segment, there was evidence of festooned pupil, pigments on anterior lens capsule, and a posterior subcapsular cataract. Otherwise, the AC was quiet. Posterior segment revealed widespread healed choroiditis. Now coming to the affected eye, vision was finger counting at 1 meters. AC showed a cellular reaction of 1+. There were cells in the anterior vitreous phase, and the intraocular pressure was 14 millimeters of mercury. Now coming to the fundus picture, there was evidence of widespread active serpiginous-like choroiditis, including macula and in the inferior periphery, and we can clearly make out that the edges are active. Along with that, there were few granulomatous lesions away from the main lesion. So a working diagnosis of right eye healed choroiditis and left eye active serpiginous-like choroiditis was made, and the patient was evaluated on that lines. In investigations, MAN2 came out to be strongly positive with 16 millimeters of induration. HRCT thorax was within normal limits. The HIV, VDRL, TPHA were negative. Complete blood picture was within normal limits. ESR was 28, and at baseline, her renal and liver function tests were within normal limits. A fundus fluorescein angiogram was performed, and in progressive frames, it showed progressive leakage, indicating activity. Also, in initial phases, we can see that in areas of granulomatous lesions, there is evidence of RAP lesion. So the patient was admitted for intravenous dexamethasone for 5 days, along with antitubercular therapy. Following antitubercular therapy and intravenous dexamethasone, the vision had improved to 2/60, and in comparative photos, we can see that the scarring has set in and the lesions were resolving. So the patient was discharged on antitubercular therapy, oral steroids 50 milligrams, and azathioprine 50 milligram OD was added. The patient was doing well. However, 2 weeks later, she presented with severe pain, headache, and periorbital swelling. The vision had dropped to finger counting at 1 meters, and on fundus picture, we can see that the edges have again become active and there was evidence of new lesions. Also, her liver function test had drastically gone bad. So the SGOT was almost 4 times the normal values, and this made us to stop isoniazid, and we had started her on moxifloxacin and streptomycin. Also, since the liver function tests were deranged, the azoran was stopped and Visolon was stepped up. In this visit, we also performed a B scan, and it showed evidence of fluid in the subtenon space, indicating scleral inflammation. So this is the clinical picture of the patient, and it mimicked orbital cellulitis. So in the next 1 week, the patient was also given a course of intravenous antibiotics. However, her condition worsened further. So there was relentless progression of the uveitis. Cellular reaction had increased to 3+ cells, and there was evidence of a subretinal abscess. In this comparative photos, we can see that in previous images, there was evidence of scarring. However, here we can make out that even in the previously scarred areas, the activity has increased. There were new onset hemorrhages and exudative detachment in the periphery. The liver function tests were somewhat normalized, and the patient was again given a course of intravenous dexamethasone for 5 days. Following intravenous dexamethasone, her vision had stabilized at perception of light, and the patient was discharged on oral steroids and the modified antitubercular therapy. So in June, when the patient came, her vision had further decreased to denying PL, and however, the fundus photo showed that the lesions were healing. So in view of denying PL vision, we had further tapered the steroids, and the antitubercular therapy was continued. In the following visits, we can see that there was further healing of the lesions. So the steroids were further tapered, and the patient was shifted to continuation phase. By November 2021, this was the fundus picture, which had resemblance to her right eye, and it was there was evidence of burnt out choroiditis. Thank you.
Over to you, sir, for your comments. Sir, you are muted, sir.
I think.
Yes, sir, you are audible now.
Now,
you are audible. Yeah.
So what Gaurav has presented is one of the most challenging patients in my own experience. Having seen maybe close to 1,000 patients of similar kind, this patient is the most challenging, the most unfortunate, the kind of outcome this patient ever had. Could we have changed the outcome? I mean, she's just a 17-year-old girl. Okay. Could we have changed the outcome of this patient? It's a $1 million question. You already told us that the right eye showed up a picture which was kind of a burnt out, uncared for. She probably never received any treatment in the right eye during her course of her illness. And, first time when it gets involved in TB choroiditis, it goes unnoticed. And I would have seen a number of such patients where the vision, not exactly light perception or no light perception, but extremely poor vision we have seen. Now, in the left eye, what you have is a very classic, I would say, multifocal serpiginoid choroiditis. And the presenting vision is poor. I think she has been, it couldn't have developed in a day. These lesions, they don't, she would have taken several weeks or months to reach a stage where her vision is down to, you said, counting finger 1/4. Is that right? And why did she ignore the symptoms, visual symptoms, for that long? The second, I mean, you rightly investigated what with HRCT, and I'm a little bit surprised that she did not show a lymphnopathy on HRCT, because I think many of these patients do have extrapulmonary tuberculosis, most of these being tubercular lymphadenopathy. And we have ourselves looked at some of the patients, and at least in 1/4 of those patients, we could take a sample from the lymph node, and which would show TB granuloma, and half of those actually we could also demonstrate the presence of acid phosphobacilli in the fine needle aspiration cytology. Now, so why your patient is not showing any evidence? Is it because lack of, we did not go over her systemic review thoroughly? That might have helped. Now, anyway, you did start the patient on anti-TB drugs and IV methylprednisolone. I would not have started this girl on IV methylprednisolone. It shows a kind of a panic reaction. If you read our first paper, which we published in 2003, I believe, that came out of a large number of patients of what we at that time called serpiginous choroiditis or serpiginous choroidopathy. And many of these patients were not responding to conventional corticosteroids. And we put them on, even on IV methylprednisolone. We gave them even cyclophosphamide. And when we gave these IV cyclophosphamide and IV methylprednisolone, these patients became frankly tubercular. There was no evidence before that. So in that series of 7 or 8 patients where we have shown by several means the presence of tuberculosis, one of them was, we thought, the use of intravenous corticosteroids or cyclophosphamide. We didn't know what was happening, and everybody said use more and more immunosuppression, use triple immunosuppression. They were saying all that in literature, and in our experience, we were ending up with some of them converting into frank tuberculosis. So I would have held my hand, giving intravenous methylprednisolone, because that would take away all the immune response from the body. So you are left helpless in the presence of a warlike situation in the eye. Sure enough, we know, and the current experience is probably 50% of these patients show paradoxical worsening. Okay. And this is somewhat similar to Jarisch-Herxheimer reaction that we see with syphilis when we treat. And that is because of the release of antigen and sudden release of antigen when you give them anti-TB drugs. And you don't know where these bugs are hiding all over the body. They are, probably dying, not only in the eye, but elsewhere. So you have a very serious cytokine kind of a storm. And I think there's a paper from Dr. Vishali Gupta from the PGI, where they have shown that at about 2 weeks after starting anti-TB drugs, the patient showed in their blood samples elevated TNF alpha. So beside other cytokines, so TNF alpha, as you know, is the main inflammatory cytokine which plays havoc with the eye. So that was something which I had been actually proposing to do that study, that there is something, which suddenly there's a kind of a stormy nature it takes. So that is seen in about half the cases, and that can be very, very discouraging for the patient to continue with the treatment, to continue with the anti-TB drugs, or continue with the corticosteroids. So because one of the patients I don't forget, because I put him on anti-TB drugs and he was already on corticosteroids and for retinal vasculitis, and young man coming from somewhere in UP, again about the same age, 18, 19 years old. And he thought when I wrote him anti-TB drugs, he stopped corticosteroids all of a sudden. He thought that since I've written a different prescription and I didn't emphasize, or probably I failed to impress upon him to need to continue corticosteroids. So he came back with the massive serpiginous like choroiditis, which took him to almost like blindness. And no matter how much steroids I gave, ultimately he had a very bad outcome because he developed avascular necrosis of the hip, the neck of the femur, and he required bilateral hip replacement. So that was such a sad outcome of miscommunication. So I think you need to communicate with the patient and the parents of the patient. The need for consistency. There is compliance has to be when you start patient on corticosteroids. Compliance has to be very good. I wouldn't have started the patient as a therapy. There was no need right in the beginning. And even if we felt the need for an immunosuppressive, I would have thought of injecting intravitreal methotrexate, 400 micrograms. And there are several reports now which suggest that we can give methotrexate safely. And I myself have given, and there has been a good response. The other option is giving intravitreal dexamethasone implant, the Ozurdex. I think there's a paper from Vishali's group, where they have given in patients who are showing paradoxical reaction. Now, the third option in this patient would have been, which I would have personally preferred. You guys being surgeons, there should be no hesitation to go in and do microincisional vitreous surgery, remove the vitreous gel. And in our own experience, which we reported with Dr. Rima Bansal several years ago, almost like 110 eyes, where we had done microincisional vitreous surgery, 23, 25, or 27 gauge. We don't call it sutureless. You have to be aware of that because many of these patients will require putting a stitch or two. So our experience was exceptionally good. And the fear that we all carry that, surgery in uveitic eyes, active uveitis inflammation is bad and lead to worse outcomes and people go blind. That's, I think, related to cataract surgery. That's not related to vitreous surgery. I can tell you that in our experience, we did vitreous surgery in all those patients, removed the vitreous gel entirely. And we found, to our surprise, that some of these patients, like the one you have, started responding even before we changed and the reason, I presume, and I believe, is because all the inflammatory cytokines get trapped in a bursa in front of the macula, in front of the retina, and they kind of get locked up. So once you remove the vitreous gel, they are easily flow out of the eye. They don't stay. They don't reach a threshold value which will be required for perpetuation of inflammation. So, the two things are happening in inflammation. One is the initiating events, which initiate, and then there are events which perpetuate or keep that inflammation going. Okay, so these cytokines which get trapped right in front of the retina are the ones which are kind of, not letting the fire in the eye to cool down. Okay, so once you allow them to exit away from the eye, quicker exit, they don't reach that threshold value, and that's how the inflammation tones down, comes down, and patient starts responding. That is one major experience, and not my own experience. If it were my own experience, people could question that. So the same thing has been reported in a large series by Dr. Soumya Basu while he was in Bhubaneswar, where he has recommended strongly doing surgery because based on similar kind of experience. So two disparate centers, two different groups reporting somewhat similar, it strengthens the idea that in these cases, we could, and in fact, in our set of patients, we could cut down on the dose of corticosteroids. We did come across 1 or 2% complication earlier in the series when we got carried away by sutureless. The inflammatory eyes, the inflamed eyes don't tolerate hypotony. So these sclera doesn't have it loses its inherent capability to spontaneously shut down those fibers. They don't come back together. So you should not leave any leaky port. So you could put a stitch there and make sure that the eye is inflated, is not hypotonic, because it will lead to choroidals, and you would again have sleepless nights. So you take care of that part. Otherwise, the eyes take care of itself. Now, what is surprising here? The second aspect, before I come to that, is the presence of multi-drug resistant MTB bugs in the eye. And we have now several publications with the courtesy Kusum Sharma, and I think in our experience, 5 to 7% of patients with serpiginous-like choroiditis may harbor TB bugs in their body, which are resistant to drugs. So these days, we don't have to really go for culture because you'll never be able to get a positive culture from the ocular tubes. But if you do a molecular testing, either by using Gene Expert Ultra or something which has come new now, or do a line probe assay, or you do gene sequencing from the amplicon that you get from a PCR product, you could, and we did find that 5 to 7% of our samples, and when we treated them on MDR treatment, specific therapy, they responded very well. So third thing which you could have done, especially when the patient lesions came back with a vengeance after 2 weeks of showing initial response. So I think that could be either because of the MDR, or more likely it was compliance issue with the patient. Young patients notorious for being non-compliant. You miss a dose and all that. But obviously led to the formation of an abscess, a scleral involvement, an abscess which went into the orbit, caused. I have never seen lid edema, periorbital edema, the kind of what you have shown in your patient. And I think I would encourage you to publish this paper as a unique poor outcome in a patient. It was a straightforward case of serpiginous-like choroiditis for people to maybe send it as a clinical challenge in the retina, or some such, as a challenging patient, because it certainly is a challenging patient. So what else we could have done? So if you are familiar with Dr. Manisha paper on the use of intravitreal moxiflox, which she gave for 1 milligram every week, and coupled with anti-VEGF therapy, Lucentis, Eylea, or Avastin. And there's a rationale for doing that. And rationale is that these granulomas, and even in serpiginous like choroiditis, there are choroidal granulomas at the end of the story. They are there. So that is a hypoxic granuloma, and it expresses a lot of VEGF. In her series of patients, I think she found almost 10 times higher levels than what you see in so much talked about age-related macular degeneration. Such a massive rise in VEGF levels in these patients. And once you give anti-VEGF, Lucentis or Avastin into the eye, she has shown beautiful resolution within a matter of days. In fact, they did not require more than 4 injections. And now we have, specifically for choroidal granulomas, there are a number of publications, I think more than 15 cases reported. And this is currently, I don't know whether you're familiar with host-directed therapy. And this is actually the host-directed therapy, where you're strengthening the host response to the presence of Mycobacterium tuberculosis to control it more effectively. It allows the uniform distribution of the anti-TB drugs into the otherwise with so much VEGF, so much capillary dilatation and leakage, the drugs don't reach out to the center of the granuloma where it needs to reach. So uneven distribution. The drug resistance develops because of that. And ultimately, eventually it happens that in that kind of scenario, it's like a monotherapy. It's not even a multi-drug therapy. So once you give anti-VEGF, so it makes a lot of sense to use anti-VEGF. So these are my straight thoughts on your patient. I think I've stretched more time on this patient, but I thought that this was, we had to cover all the aspects of this.
Yes, sir. Absolutely, sir. There's no, as such, your time is more important than us. So
I'm
we will be
free
happy to listen to you, sir, as long you can.
I'm a free man and I express my views.
We also, on the hindsight, we also thought, because there were granulomas to start with, also we could also identify RAP lesion on FFA. Yeah. So we could have injected anti-VEGFs, and that point of not to start these patients on IV dexamethasone and immunosuppress them to that extent is well taken, sir. And that should be what we should be doing for these ocular tuberculosis patients. Thank you so much, sir. We can move to the next case, which is again on tuberculosis. And Dr. Pranav would be